Yeah, yeah, thanks. I mean, I'm looking at kind of four different areas that we're talking about. One is what's happening, epidemiologists. Second is ACS. Third is enforcement, and the fourth is Latinx, kind of that we've kind of gone through. So, Dr. Mase, just a few questions on where we're at, right, with some of the numbers to start with. I believe last week you said that 61% of our positive cases really came from contact investigations, which would note that 39% are like community transmission. We don't know where they're coming from. Do you have the numbers on that, or where we're at? Does that sound right?
Yeah, we're working on that. That's another data, just like the other things that we're looking at, so that we can try and figure that out. But yes.
But was I wrong I might have heard that wrong last time. Does that sound like, I mean, are we at 50-50? Like, hey, we don't know where this is coming from, or is it one way or the other? In the early days, you were saying that all the stuff was really coming from contact investigations before we reopened because it was easier to track. Is it trending the opposite direction, or should we wait and get a report on that later?
It is trending definitely towards more community transmission. That I can say for sure. It's a matter now of trying to figure out exactly what that percentage is, because what's up in the dashboard right now still suggests that community transmission is less than 20%, even like 15% or so. But I think it's greater than that. It's just that we haven't had a chance to evaluate about the last 250 cases. So as soon as epidemiologists are able to do that, I think we'll have a much better understanding of that.
Okay, excellent. Next question is with respect to the hospitalizations. It looks like the main reason that's listed on our notice from the state, while you showed us a couple of different areas where we're right on kind of the cusp of red flags and others, cases per 100,000. We have more than 100, we're up higher. But the core one that they've been referencing to us is the percent increase in hospitalizations. Is that correct? Is that like the big one that they're tracking?
Yeah, that's the one that they're flagging us on.
Yeah, and is that level of hospitalizations really driven by the fact that this got into our skilled nursing facilities and our other things? Because one would think that vulnerable population goes at a much higher rate to a hospital than somebody who's 21 years old.
Yes, it's partly driven by the skilled nursing facility outbreak, but there have been numerous hospitalizations not related with that.
Okay. There was a slide you pulled up that had total cases of hospitalizations, confirmed cases, and suspected cases. Can you tell me what suspected cases means?
Yeah, people who go in the hospital that are thought to have COVID and admitted because they're being evaluated for COVID, but end up with a different diagnosis.
Okay, so false positives, not
people who
go in
the hospital nevertheless, and then they're evaluated.
Okay, it's still the hospitalization. So the hospitalization, just staying on that for a minute, it's an interesting one because the hospitalization rate seems like a very good criteria. The second question though is that the ICU bed rate is more of a dynamic one, because we have surge capacity if we staff it to be able to increase our ICU numbers. Is that correct?
Yes, we do. Yeah, so in other words, that ICU bed capacity looks at staffed beds, does not total. So that's why that surge capacity of 30% exists. If the hospitals were to pull staff over to staff the ICU beds, they'd get 30% extra capacity.
Okay. And of the ICU bed space used, of that high percentage with 64 out of 65 beds, what percentage of those are COVID, or what number of those out of 64?
Yeah, like you can see now we probably have about 10 hospitalizations total of COVID, but even of those, even a lower proportion would be in the ICU. So I'd have to ask the hospitals exactly, and actually the image trend data would show that, but it's probably more like 6 or 7 people total in the ICU.
Yeah. So it shows you, I guess it reinforces what you're talking about, which is the hospitalization rate is more relevant than the ICU rate, because the ICU rate we can swell it, we can surge it if we need to, but It's also being driven, a lot of it, by non-COVID related maladies, right?
Yes, but the reason the state tracks that is because that's what will lead to really bad outcomes is when those ICU beds are maxed out. That's when patients start being transferred to other counties and stuff.
Okay. You said that that the data is showing, or the contact investigation, that workplace transmission is 10%, is I think what you said, right?
Mm-hmm. Yeah.
And so that's where we're trying to get numbers on how much is from family gatherings, how much is from outside. But I think that's an important thing. We're not seeing the majority of transmissions from the workplace right now.
Right. So the point of that is that although people work in those areas, like they work as, you know, in whatever environmental services or sales or whatever, doesn't mean that the transmission's happening at their work site. That's just where they work. 90% of them got COVID outside of the workplace.
One of the things that we're asked a lot is, and I know you are too, is if we're seeing any impact from the protests. And that's not a loaded question, looking at it for any way or the other, but there was obviously a lot of large gatherings that were unmanaged. Any correlation you're seeing there?
With what? Yeah, you cut out for just a minute. With which activity?
The protests.
Protests, yeah. So that's
any
one
correlation
of the,
with increase?
Right. So what we're doing is asking people as they show up as cases part of that protest. So that's another area that epidemiologists look at to see what percentage of cases say they actually were at protests.
Okay, good. So you said I'm just confirming you're seeing some cases come in from people who've been traveling out of county.
Yeah,
right?
Yeah, that's
and then I assume
uptick.
And I see I would assume at the same time is that when people who visit Sonoma County, if they go back to Alameda County or whatever, and they have COVID, those are on their numbers, not on our rolls. We're not at the capacity where we can track, like Alameda doesn't notify us if a hotspot came from us, right? We're all tracking source material, our tests here.
Right, unless somebody tested positive in a different county and they're our resident, then we, of course, are notified by them. But other than that, we're not at a level of saying, oh, we got 10 cases from you. Now,
If I could add to that, I do think that on a case-by-case basis, for example, we heard from Napa and Solano, where there were residents in those counties but work in our county, where they tested positive. So there has been, starting to be more communication across jurisdictional lines to try to figure out, okay, is there a concerted, coordinated effort we can take in terms of trying to address that? So that has just recently been a development, Supervisor Gore.
Great, thank you. Are we being used yet, or do we anticipate that we're going to be receiving folks from other counties where they are overburdened, i.e. Imperial County, where they just don't have any room? I know I've been hearing this from my CSAC work, as a lot of other counties. Also San Quentin prisoners. How's that working right now?
Yeah, so as far as receiving patients from other counties, there was a call for who would take those patients, but because we're not close to Imperial or Stanislaus or any of them, we haven't gotten those transfers. If our neighboring county got overwhelmed, then we may be more likely to take their patients because it's just a distance of transfer. Mm-hmm. Now, with San Quentin, that's a different issue. We have received at least one person from San Quentin to a hospital, but they'll just transfer people to wherever they see they're fit. And there is not much notification or heads up, but the person who needs hospitalization will come, basically. And so, we don't have a lot of control over that.
We have, you've oftentimes talked about the amount of time before COVID would be able to be expressed by a test, right? So people have talked about 10 days. I've heard you say up to 14. What's the knowledge now of what's the time frame that, like, if I'm around, if you have COVID and I come in and I'm with you, it could be as much as 14 days before I could test positive, or as much as 10 days? 14
days is the period within which you could become a case, after your contact.
So I could be around somebody and I could get 2 tests once a week and they could come up negative and I could still
Exactly.
express COVID 14 days later.
Which is why we're testing all the contacts to people
Yeah.
at the end, sort of. We're testing them
Well,
at 12 days.
And this gets back to a conversation that we've all had, but is you're using our county public health lab, our 150, 160 a day to do contact investigation. The second is anybody who's symptomatic. I'm trying to confirm, make sure I have this. Anybody who's symptomatic needs to go through their healthcare provider because they're getting faster turnaround times than OptumServe, which is horribly backlogged right now.
Right. OptumServe is probably then not the best place to be tested if you're symptomatic and sick. You should go to your doctor because they can, if they really think you have COVID, send the specimen to our lab for much quicker turnaround, or even perform a rapid test. For example, Memorial has the capability to do rapid testing, and so does Kaiser. So I think there's a lot of alternatives to going to OptumServe. OptumServe is really for people in the community who aren't ill, who want to know if they test positive, they're asymptomatic, or they went to a protest, or they went to a restaurant and they were concerned. But there's no indication that they have COVID. They're concerned that they might and be asymptomatic. Those are the folks that you should be going to OptumServe because it is taking 5 to 7 days to get an appointment. And then after that, because of the Quest lab backup in results and performing the test, it's taking an additional 5 to 7 plus days to get the result back.
I got a test at OptumServe last Wednesday, and just keep getting things from them that say they're delayed.
Yeah.
So obviously the concern there is that if somebody goes for an asymptomatic test and they have to wait 7 to 10 days, they can't isolate and quarantine that long if in terms of what they're waiting. But we can't control that. That's a backup at the Quest labs and other things. But it remains to be seen. One thing I want to put on the to-do list for the Latinx task force is to look at most of a vast majority of our farm workers and our Latino service workers utilize our healthcare clinics, our FQHCs, our federally qualified health clinics.
Yeah.
And so, the question I have is, do the FQHCs are they using our county health lab? Are they just sending people to OptumServe, or where do we know how they're referring people?
Yeah, they're pretty much using Quest, but they test themselves. They do the test and they send it to Quest, unless it's somebody who's really high priority, and then it comes to public health.
So I guess just
they'll let us know if it's somebody that they need a quick turnaround time on.
So they're able to prioritize. If somebody comes in and call, we really need to get
for the majority of people, they're sending it to Quest. But if it's a staff member of theirs or something like that they want to quickly get results on, then they call me or someone at public health, and we'll arrange for them to have rapid testing.
Well, I think it bears to say, with you talking about 14 days to express COVID, and then at the same, if you catch it and it takes 14 days, but if our numbers go up, you can't pull the data. We're being asked to act, or demanded to act, by the situation and by the state before we have full data on what has created the surge, right?
Exactly.
So there's a lot of this that, as much as we track our data, it's assumption-based, or what you're hearing from the contact investigators. Hey, a lot of this is coming from indoor gatherings with families, right? Things like that.
But, I think once our epidemiologists really look at the data in the last 250 cases and comb through it and see what the exposures were, we may, at least for the gathering question, we'll know, that this percentage of the cases in the last 3 weeks occurred because of, likely because they went to some kind of gathering versus not, that kind of thing.
Yeah. So I wanted one other thing okay, so the state oversight, right? So let's just assume we are now on day 3, right? We are moving towards implementing the governor's order from July 1st to shut down the sectors that you identified. The state has a task force. They talked to us about that. ABC, other licensors for things, so they're going to come in strong too. So this really, the question I have is that, now that we're on day 3 and we're going to get a positive and say, yeah, you're 3 days in, does that mean that these sectors are going to be shut down after 3 to 4 more days of consultation, like next week, or are they going to be shut down tomorrow or Saturday?
Yeah, the state's plan would be to discuss with us for 3 days what is going on, so we can give them our data. That's why I asked epidemiologists to try to get this data together on more specifically where they think these latest cases are coming from, so we can share that with them and say, okay, this is where we think our problem spots are. This is where our hot spots are. And then they will weigh in and see if there's some way I think that we can potentially, I'm not sure because I haven't been through the process yet. I assume that they'd want to talk to us about potentially tailoring some of the, some other ways that we could deal with situations that are specific to our county. Now, having said that, I know from the other 19 counties that have gone through this initially that what the governor stated is going to happen last week in terms of shutting down things is what they move forward on.
Yeah, I've heard the same thing through the county network. Is even though there's consultations, it's pretty much here, shut these down 3 weeks, exactly. and then we're going to track and talk to you. So, so I just mean it's fair to assume right now that you are going to be in conversations tomorrow through the weekend, and that we are going to have to early next week. I think that's fair to say to our community is going to have to shut down those areas in the governor's order.
Yeah.
Okay. So under that scenario, I think it's one thing that's interesting is before we had the meal requirement for tasting rooms, but it looks like that's not there for winery tasting rooms, but it is there for breweries. And I know that the wine industry was lobbying the governor's office about that and other things, but every brewery I know serves food too in Sonoma County, so it's not a surprise. Okay, so a couple things I think that are relevant for us is that in my meeting with the governor last week, we've talked about this. They are still planning to let the CARES Act come out monthly, meter it out monthly, which is how they are going to hold oversight over counties so that they don't go rogue, right? If you want the CARES Act money, you got to be there. It looks like we're good on the realignment backfill, which is for our safety net. This is more for maybe yourself or Director Robinson. The ACS. So it sounds like you gave a presentation, but it sounds like even though it's a big problem that we had to move out and do all that, we have options on the table where we don't need to be extremely concerned right now. You guys are working on it, and it sounds like.
I think we will have a great update when we come back in 2 weeks. We've moved expeditiously, and I'm really grateful. I just want to shout out to community partners who stepped up to help support our efforts. And so I feel that we're in a great place, and just grateful to SSU for their service and the time at their university. Great.
What about, so we have 2 different kind of areas there at the ACS. One is the highly vulnerable individuals that you talked about, homeless individuals. And then the other one was people who test positive, the ability for them not to go back to their apartment where they have a lot of people living and go stay there. I think we talked about this with Latinx families that have, high population living conditions. Is our next iteration going to provide that opportunity as well?
Yes,
for people?
Right. We've tranched that out. Contrary to public perception, we have been working diligently on transition plans and off-ramping for some time, actually since the beginning. And we have resources and opportunities for all of that, and we'll lay out the entire plan at the next update.
Well, it shows you it seems to be a gotcha moment every other day, but the reality is that things are moving. Okay, so the final. Okay, so ACS, the trailers are requested, so we can all reach out and try and encourage the state to give us 24 trailers. Would that be helpful?
Yes, that was part of it. We've been in negotiations and conversations about that. And so any additional getting us over the finish line that you can provide is always greatly appreciated. Thank you.
Okay.
And this is Christopher. This is Christopher Galley, emergency man. I would just mention that in the last 15 minutes, the state has indicated the first of the trailers will be arriving tomorrow.
Fantastic.
Thank you.
Great. Compliance and enforcement, I'm looking forward to Chair Gorin when you get into that. I talked with Mendocino County Supervisor yesterday. They put in, actually, they have two different kinds. One of them is the ability to shut down non-compliant businesses, and that's not being used a lot. It's more so for the people who are just like, I'm not going to shut down. These are my rights. Screw you, right? So they did have to shut down one establishment in a small town in Mendocino and have a $10,000 kind of fine on there. But the other side that Mendocino implemented was a citation for masking. They were having a lot of issues with people not masking. So there's two areas we need to talk about, right? The masking one was, I think, for $100 first infraction, $200 second infraction, $500 third infraction. Sounds like kind of a seatbelt ticket, right? I think we might, if we want to encourage people, we might have the first one be a warning. But like, maybe, Zeke, you talked about laundromats and other things. We might have to think about how we continue compassionate enforcement, but how people know that they also have to protect others from themselves. So I think that's an important conversation. And with that, I think the big key there for us is I do support the idea of civil enforcement. I know there's always a question of if this is police, if this is all police and sheriff, but I do like the idea of our civil enforcement. And then secondly, if I go into the Latinx, I'm really interested in how much this is Director Robinson. A case management is going to cost money, and we've already talked about allocating potential CARES Act dollars to support that. I'm interested in, even if we get the money metered to us, the CARES Act out of the state, is do we need to float some of the money until we get those payments back to create the kind of public-private partnership that we need, which is some of the community foundations, us, others, some people paying staff, some doing others, but we got to help people pay rent, pay bills, and do other things, which is a part of keeping them in. You have the ESG money. You have, on the other side, potential CARES Act money, which could go towards undocumented and other things where ESG can't. So I have to ask, how much, what do we need to think about setting aside?
So I think I don't want to get ahead of myself. We were going to do the proposals and ask folks to submit their bids for what it would cost based on the elements that the health work group has laid out that they believe are critical components. And so I apologize, I don't have a number for you today, but we are working diligently to bring that back along with a broader, the COVID unit, because this would be part of, that section and the work that is overseen by the department in partnership with the Latinx work group.
Well, I think I want to make sure I link up well with you guys. I also have a meeting this coming week with Catholic Charities that has money from the Listos program, which is for preparedness. We need to link in you and also Chris Godley from DEM on that. And that's me for now. Thank you, Supervisor Bourne. Looking forward to any action items you want from us. I just assume that the case management, we're going to have to, it's going to be more than $750,000. It's going to be $1 million plus of CARES Act money into case management. That's just my thought. I think we're more in the area of more than $1 million too. So I just want you to stay close to us because we're going through budget and we have to figure out how much CARES Act money we're going to utilize internally to respond to COVID and how much we're going to have to put into the community to not pay for it all, to get the community foundations and the private companies and the nonprofits to come and match with us.
So today, what we're going to be talking about for our update is the status of the alternate care site and the non-congregate site and the transition. The California Department of Public Health County Data Monitoring Program and where we are with that. The California Department of Public Health guidance on closure of businesses and where we stand with that. The local COVID-19 data tracking, specifically the Latinx community data and response, and then on community health. So as you know, we are in transition with the alternate care site. And the timeline is as follows. By July 16th, the last of the COVID positive and COVID pending patients will be discharged from the current alternate care site. By July 17th or sooner, we're going to establish Roseland Village as our centralized medical and supply inventory and storage staging area for the alternate care site and for the non-congregate site. You can see a timeline. So 16th and 17th I've spoken to. By August 4th, we'll have the final demobilization of the Sonoma State University occupied buildings. And by August 5th or sooner, the alternate care site will be operational in a different site. Currently, we're negotiating with local hotels and vacant office parks. For the non-congregate site, this is the unstably housed COVID vulnerable population. The locations under consideration are Alliance Redwoods and Camp Meeker to utilize the conference facilities for up to 10 months with the Redwood Gospel Mission providing supportive services, and the Flamingo Hotel with additional rooms available after July 22nd. And there have been many efforts to date as well to boost this. We've secured 8 additional rooms at the Astro Hotel for the most vulnerable individuals who are currently at Sonoma State University. And then there's the Homeless Encampment Access and Resource Team providing intensive outreach at SSU for shelter placements at the Mary Isaac Center and Sam Jones Halls. 30 beds are available here. And we requested 24 additional trailers from the state for use for housing these individuals as a non-congregate site. So now I'll move to the California Department of Public Health County Data Monitoring Program. You can access the website to see how this whole process works, but in short, it's a state partnership with local jurisdictions to monitor data and protect the public health through daily data monitoring. They are a little bit behind us here at the county because we're also performing daily data monitoring, but their data is matching ours fairly well. And then from the state side, they would place counties on a watch list if the data indicates that there's a cause for concern. And once the counties get on the watch list, there will be targeted engagement with the state, with counties and the state to reinstitute community measures, restore containment if the numbers remain out of compliance. So what is being monitored by the state? We are looking at the following indicators. There are 5 indicators. One is the capacity to perform tests. It actually isn't just the capacity, but the actual number of tests that are occurring per day, per 100,000 population. For Sonoma County, we need to at least be doing 150 tests per 100,000 individuals per day. And right now, the 7-day average is 160, so we are fine there. The case rate per 100,000 population is another indicator of elevated disease transmission. So the case rate, if it's over 100 per 100,000, that in a standalone metric is a cause for concern. And right now, our data shows that over the past 14 days, our case rate is close to 108 per 100,000, up from the last time I presented from about 70 per 100,000. And as you know, about 5 weeks ago, we were at maybe 20 per 100,000. So this kind of tells us that our numbers of cases based on population has gone up about 5 times in the past 5 weeks. Our testing positivity is another way of tracking elevated disease transmission. That's the total number of positive tests over the total number of tests performed over the last 7-day average. So what percentage of our tests that are being performed are positive? We're at 3.3%, and the threshold is 8% with the state. So we have met the metric of elevated disease transmission by having a case rate of over 100 per 100,000 over the past 14 days in average. The other indicator that's being looked at is increasing hospitalizations. So a 10% or higher change in the 3-day average in hospitalized patients is considered a red flag. This is actually the percentage that the state is calling us out, stating that we've been on meeting the metric for being on the watch list for the past 2 days. That would have been Tuesday and Wednesday. Have not received an email from them yet today, but I fully well intend that they will receive an email stating that we're out of compliance with this metric. As you can see, we've had a 54% increase in hospitalizations over the past 3 days. In other words, a 3-day average increase. The other 2 indicators the state is looking at is the percentage of ICU beds that are currently available and the percentage of ventilators that are currently available. If you're less than 20% in terms of ICU bed availability, you're in the red, or again, in a red flag situation. Currently, I think 64 of our 67 ICU beds that have staffing, that's the way we're looking at it, are filled. So we have 3% of our ICU beds available. And for ventilators, we're fine. We have 80% of our ventilators available. Now, the ICU beds, those are the beds for which staffing is currently available. So by surge capacity, what we mean is the ability to increase this bed availability by 25 to 30% with additional staffing. Although we're looking at 3% availability, this could be expanded with surge capacity. You can see our rising Sonoma County case rates. The state is a little behind us in calculating our case rate, but we have made the metric for the state for being on the red flag warning list and getting on the watch list since July 3rd. We've had a case rate of over 100 per 100,000. Here's a graph showing the increase in our hospitalizations over time. The total hospitalizations is in purple, confirmed cases in dark blue, and suspected cases in light blue, and they are increasing over time. And as I said, we had a 57% increase in hospitalizations over the last 3-day average. Here's our declining critical care capacity. Now, granted, all this is not due necessarily to COVID positive patients in the ICU beds. It's total overall ICU bed availability. And there are some thoughts to why we are having more persons in the ICU. One of them might be that people have not been seeking care due to COVID and sheltering in place, or they have been unwilling to go to healthcare facilities because they don't want to be exposed at high-risk areas like urgent cares, emergency departments, physicians' offices, things like that. So perhaps the fact that people are not seeking routine or kind of more urgent care then causes them to come to the hospital sicker and possibly be admitted to the ICU. This is just one potential reason why generally ICU beds are being used in hospitals. Here again is the percentage of staffed ICU beds available, and you can see since really the end of June, we have been under that 20% of staffed ICU bed availability. We have also seen an uptick in deaths. As you noted, we were sort of steadily holding at 5 deaths reported until the end of June, at which time we saw an uptick, and currently, I believe we're at 14 deaths. So we've added 9 deaths, primarily in our skilled nursing facility patients or patients that are in residential care facilities for the elderly. We have, as I just alluded to, outbreaks among vulnerable populations. We have had now a total of 95 cases in seniors, that is in skilled nursing facilities or residential senior care facilities. Of this, staff have made up a total of 39 cases, and residents have made up 56 cases, with there being 21 cases in staff and 34 in residents in the skilled nursing facilities where patients are cared for, and 18 staff cases and 22 resident cases in assisted or senior living or board and care homes where elderly persons live, but they're not patient care facilities. So 58% of our cases have occurred in skilled nursing facilities, 42% total in assisted senior living facilities, and they've been more heavily tilted towards residents rather than staff members. About 2/3 of cases are occurring in residents. So if Sonoma County remains out of compliance on the metrics today, which would be our third consecutive day, we will then join the 23 other counties on the California Department of Public Health targeted engagement list. And the state will work with us to identify action steps and timelines for addressing issues that impact the indicators of concern, specifically for our county. And counties that remain on this watch list for three days then are required to comply with the state's July 1st order, closing the following businesses for a minimum of 3 weeks. And that would include indoor dine-in restaurants, indoor wineries and tasting rooms, indoor family entertainment centers, indoor movie theaters, indoor zoos and museums, indoor card rooms, and all brew pubs, breweries, bars, and pubs, indoor and outdoor. If these businesses serve meals, they can operate outdoors. So we'll go back to the food, pairing food with drink in these institutions. So this brings me to the subject of enforcement, and the reason we were talking about that here is because one of the reasons why we may be out of compliance in terms of state's metrics with increasing numbers and rates of cases, as well as increasing hospitalizations, may certainly be due to people not following the orders and the mitigation measures that we put out, such as the facial coverings and the social distancing, but also the mass gatherings. So if we look at our data, definitely we have a lot more community transmission cases, meaning people who are popping up as cases with no apparent exposure, but we also have cases associated with gatherings of over 10 people, over 12 people in different settings, whether it be in funerals or whether it is as Father's Day or gatherings, Memorial Day gatherings, whatever it is, we're seeing cases from those kinds of events that at this point are still not allowed by the state order. So the enforcement now of the orders is currently driven by complaints to local law enforcement, and then the choice of, or the ability of law enforcement to go out and enforce the order. There's also a state strike team for watchlist counties, and that like ABC or licensing agencies that could be used. Environmental health, for example. There is a potential need for county-driven tools like inspectors for environmental health, also ordinance for and inspectors for education in the community at the county level. And then a need to incentivize compliance to drive down these infection rates. So the more we are able to adhere as a community to the mitigation measures that include limiting the gatherings and especially, of course, outside of household gatherings, as well as the facial coverings and the general social distancing, physical distancing, general hygiene measures, screening of employees, not going outside of the home if symptomatic, instead seeking testing and that sort of thing. If we aren't able to adhere to these things well, then this will drive our cases. So looking at further state criteria, which is the stability of hospitalizations, we are now over the state criteria for the stability of less than 5% change in hospitalizations over the past week. We actually have a 17% change in hospitalizations over the past week, average daily percent change. And we have not yet met the metric of having more than 20 hospitalizations in any given day. So now we'll look at the characteristics of our hospitalized COVID patients. Again, about 40% ever in the ICU. And we have 1/3 of patients in the 0 to 49 age group, 1/3 in the 50-64, and then 1/3 in the 65 plus. The majority have recovered, but we do have a group of active patients that are still hospitalized. And then we have an increase in the number of deaths in hospitalized patients. It's the gender splits 50-50. And you can see again, the majority of people do have underlying conditions. Still about 1/4 don't, but the majority do. The state criteria indicating limited hospital capacity. We already looked at our ICU bed availability, the ventilator availability, but then we should add that now at the hospitals, there's a 4 to 14 day supply of PPE, which is less than the 14-day supply, greater than 14-day supply that indicates that we're in a good place here. So it means that we need to start looking at our PPE supplies in hospitals as well as skilled nursing facilities and ensure that we have enough PPE. Testing capacity has been overall good. The low blips are usually weekend testing or that when there's a problem with testing for whatever reason. A holiday, I think, could also drive this. I just want to mention that we have now some preliminary results for the antibody testing that we've been doing in first responders and healthcare workers, and of course, in our former cases that are recovered in contacts. And the real highlight here is to note that the majority of our cases, 90% of them that have tested, and that's a small number, only 36 cases actually, as of when this data was put together, came in for testing out of our, 1,300 cases. So we are working on getting more cases in for testing, but of them, 90% were positive on antibody, which you would expect because they actually had COVID. Of the contacts, again, a very small number of 39, we can see that a small proportion, about 8%, were positive on the IgG antibody test, but that's greater than what we're seeing in other groups. So as you'd expect, contacts are at high risk and tend to be more positive than, say, for example, the entire first responder group, for example. So amongst first responders, and we haven't looked at a subgroup of just the first responders that had cases like Santa Rosa Police Department, but we looked at all first responders. Only for 3.8% of them are positive on the IgG test, which is a very low proportion given this is a higher risk group that actually had cases amongst them. Healthcare workers are, again, an even higher risk group than first responders since they're treating the patients and constantly at risk for being exposed to COVID. And of them, 6.6% were positive on the antibody test, as you'd expect, but not as high as the contacts. So contacts clearly are even higher at risk than our healthcare workers that have no known contact. Other professions, interestingly, 0 had IgG positive, which you'd suspect that the time when we were doing this antibody testing, there wasn't yet a lot of community transmission with cases popping up. Now we have a little bit more. And then there is an unknown category as well, but that gives you kind of the flavor for what we're seeing. Interestingly, if amongst those who got tested, whoever had symptoms, 12.5% were positive. If they didn't have symptoms, only 3.7% were positive, as you'd expect. So now I want to move to the Latinx community and state, we still have this extremely disproportionate number of cases in the Latinx community. As you know, we've been doing a lot of outreach to the community and testing and offering other education services. And I think Director Robinson is going to speak more to this shortly. But you can see the percentage of cases has decreased. It was as high, I think, as 77%, and now it's down to 65%. And the cases occurring in white non-Hispanic self-described persons is 20% up, I believe, from a lower number last week. Why is this? Because we're seeing more transmission in other communities. Again, one of the reasons why the Latinx community was so hard hit is because they have been the ones that have been out working ever since day one and more likely to be exposed to COVID as a result. And then with the large family groups and worksite groups, there's been a lot of transmission. Now, as we see a change in COVID epidemiology to having more community transmission, we're seeing the Latinx proportion go down a little bit despite our enhanced testing and outreach to this group. And the other group, really chiefly the white non-Hispanic group, increasing because we're seeing community transmission in groups that were not previously seeing COVID, essentially. Still, the disparity is huge and needs to be addressed as we're trying to do so with our numerous different interventions and activities that Director Robinson will speak to. Employment sectors haven't changed in terms of stratification by race or ethnicity. Still, Latinx cases are occurring in agriculture and farm work, in the construction-related trades, in food and beverage production, landscaping and outdoor maintenance, cleaning, janitorial and environmental services, sanitation and public works, transportation, caregiver, and personal help. And you can see that the flip side of where COVID-19 cases are occurring amongst white, non-Hispanic, self-described individuals. Again, a caveat that workplace transmission accounts for less than 10% of cases. This is where people work, but it's not usually where they're getting COVID. We have been very successful in recruiting bilingual staff. You can see that we've added, already hired 15 contact tracers, 2 intake workers, and 1 nurse, bilingual, and then 1 non-bilingual contact tracer. So we've really been successful in getting bilingual staff on board. Pending, we have another 15 contact tracers, 5 intake workers, and 4 nurses who are bilingual, and 2 contact tracers and 6 nurses who are not bilingual. So we are ramping up our efforts to get new staffing in for our case management and our contact tracing activities. Moving to balance measures, still our data shows, and the numbers are very low, but shows that since shelter in place was implemented in March, there was a trend of heightened overdose deaths in March and April, but it fell below the average levels in May and June. Suicide deaths have been occurring less frequently than average since March 2020. Again, it takes time for these reports sometimes to catch up, and given the small numbers, it's hard to make a lot of conclusions from data like this, given that there's such few numbers in these categories. The warm line has been used. It's been up and running since the end of April. I believe that the more that we advertise warm line, the more use there is. So we need to probably advertise warm line services again. You can see that the top 5 reasons for calls were anxiety, resource needs, loneliness, other, and then overwhelm as a cause. So we are definitely getting use of the warm line. Child abuse and neglect allegations had really dropped off since shelter in place, but now that we are relaxing at shelter in place and children are back into daycare settings or camps and such settings, I think we're having more reporting again of these kinds of allegations.